Great. Hi, everyone. Welcome back to Mayday, Mayday 2, our symposium on workplace mental health and injury prevention. And this session is session C, which is the COPSOQ/workplace mental health survey use around the world, which I think will be quite interesting. We have people from literally all over the world here and online that are going to share their experience with us. We're going to start off with the new U.S. Healthy Worker Survey update from Marnie Dobson, who's the director of the Healthy Work campaign. So Marnie, you got your slides up. Let's take it away.
Sure do. Thank you, Val. And thank you for inviting me. I think this might be the third year in a row I've been part of the Mayday meeting on workplace mental health. And so I'm really happy to be here to present some updated results on our Healthy Work Survey, which some of you may have heard about before from maybe last year. I'm not sure how many folks are new to this meeting, but I'll give a little background. There's not a lot of psychosocial work stress survey research or surveys coming out of the US. So we'll talk a little bit about what drove our small group to undertake this and how it's going. I'll give a little overview. So I want to acknowledge my team. We're all colleagues that work in various universities, as well as for the Center for Social Epidemiology, which is a nonprofit center founded by my colleague, which some of you may know, Peter Schnall. We're also working with Dr. Paran Fagri from the Center for the Promotion of Health New England, who is now at UCLA. David Legrand, who was the former National Health and Safety Director for CWA. And many of you may also know Paul Landsberger, a colleague as well. Let me click on here. So we launched the Healthy Work campaign, just as a background before I talk about the survey, in 2018 with the website healthywork.org. And it really was an extension of the mission of the Center for Social Epidemiology, which is the nonprofit organization we work within or under, to raise awareness basically about the impacts of work stress on physical and mental health. I think we're all safe to say that in the US, we're somewhat behind the curve in dealing with psychological health and safety and mental health in the workplace. Although I have to say COVID has, I think, made an impact on the awareness of workplace mental health and the importance of attending to psychological health and safety issues. I think there has been somewhat of a groundswell. As part of the Healthy Work campaign, we wanted to create some tools and resources for organizations. There is, a pretty broad list of centers for total worker health throughout the US, and many of them do have research ongoing into psychosocial issues and mental health, especially in this last round. There are now 10 centers. And of course, we have some national surveys, which are somewhat poor in terms of measurement of work factors that we know are from the extensive global literature in this, a common factors in affecting mental and cardiovascular health, for example. So we wanted to create something that was more user-friendly, not just for research purposes. And I'll talk about the Healthy Work Survey and how we went about creating that in a moment. We also, realized the survey is a first step, and really it's a starting point to take a snapshot of an organization. So we've also been working really hard to kind of create and translate the excellent work that's being done out there on intervention research and on other strategies that can be implemented to improve work organization and reduce psychosocial stress. And as well, part of our movement as a public health campaign is really to inspire action and form a coalition in the US specifically to really share the message and increase awareness about this impact of work stress and work organization factors that needs to be addressed in order to improve job quality and health. So we have a growing list of partners, one of which is OCAL, who were one of our very first partners. We were able to recently feature John Udike, who is a good colleague and friend and has worked with us pretty closely in the development of the Healthy Work Survey. We featured him on our recent Healthy Work Campaign newsletter, talking about OCAL and all the good work that's being done there and with Stress Assess. So some milestones, background, as I mentioned, we launched the campaign with a pretty extensive website, 2018. And then between 2018 and 19, we began development of the Healthy Work Survey and validation of the NIOSH quality of work-life scales. And I'll talk about how we ended up focusing on the NIOSH quality of work-life questionnaires in a moment. Between 2020 and 21, we conducted expert reviews of the survey and the validated items that we considered to be part of the final survey. And we got feedback from occupational safety and health experts, some of who may be in the audience, including John and others. We also field tested the survey once it was developed online through this online reporting system that a colleague in Colombia, Sebastian Segura, who has a company that responds to organizations because Colombia has a legislative mandate that employers surveil their workforce annually. So he had developed his own survey system that helped to bring employers into compliance with that assessment system. So he developed one for us to use through 2021. And we were able to launch the Healthy Work Survey for individuals in January 2021. And then we developed the organizational report system, which I'll talk about as well in a moment, and launched that in September 2021. Just recently, we published we published online a validation paper about the survey development in the Journal of Occupational Environmental Medicine. It's available online, it's open access, so you can just click on the Journal of Occupational Environmental Medicine and look that up for more information. But really prompted, it prompted us back in 2017-18 that there weren't any sort of online, easily accessible, standardized tool to measure psychosocial hazards. We reviewed the literature on existing psychosocial measures. We talked to John, of course, about Stress Assess that used COPSOQ data and then Canadian national data. The NIOSH well-being questionnaire, worker well-being questionnaire, they call it the WellBQ, was also under development at that time. It had only been deployed, I think, just before September last year. September 2021. But it is not available online. It does have some overlap, although I think we have some more of the psychosocial aspects in the Healthy Work Survey. We also reviewed the COPSOQ. We have a couple of questions that are part of the Healthy Work Survey from the COPSOQ, or at least adapted. And it describes the paper describes the validation statistical psychometric analysis. And it gives a pretty thorough description of the expert feedback process and the development of the online system, and also the beta testing in the field with workers. So a quick, overview. I won't go into too much detail because we have the paper there to read, but after the review, we decided on the NIOSH Quality of Work-Life Questionnaire to serve as the basis for the major work components of the survey, because we wanted to be able to compare scores to US norms. And we evolved a database based on the NIOSH Quality of Work-Life data from 2002 to 2014. Excuse me. By the end of it, we were able to incorporate 2018 data. And we were able to conduct factor analysis, reliability analysis with the convex alphas, showed pretty adequate reliability after the removal of some items. For example, we have items that are just around 0.6 in terms of the convex alpha. Predictive validity, we run tests to look at the correlations between these scales that we validated for the first time, really, because NIOSH has not done the work to validate these particular scales in a standardized way, or analyze the data on an ongoing basis nationally. Major scales showed correlations to 10 of the general social survey health outcomes, including everything from back pain to the CDC Healthy Workdays questions on poor mental health, poor physical health, general self-reported health, and so on. As well, in 2019, we wanted to include sort of emerging items that weren't part of the NIOSH Quality of Work-Life questionnaire that we found from the literature were showing, significant, to be significantly predictive of mental health and other physical issues, including organizational justice, electronic monitoring, some items on wage theft, and scheduling changes, emotional labor, which I believe we adapted from the COPSOQ questions on emotional demands and emotional labor, and workplace physical violence, among some others. So as well, part of the validation was to create a risk group, a 3-group risk classification system. So based on the multi-item scales, we derived tertiles from low risk to high risk, and we were able to determine the percentage in that quality of work life data set that were, fell into the low risk category versus the high risk category. So when you see the report that we generate based on the Healthy Work Survey in these items, we're able to, compare the percentage at risk in the US population to the percentage of risk in the Healthy Work Survey, and that's automated. So it's not something that we have to do. It just happens automatically. So the final survey has 55 items. We tried to create a short survey. 55 items does sound like a lot. However, it also includes the additional items from the validated psychosocial questionnaires and these emerging items that we felt were important, as well as some items that we included on physical hazards. So the primary core scales and items are 55 items altogether. And we have some supplemental questions. We have the health outcomes. There's 16 items from the GSS Quality of Work-Life Health, and some additional items on presenteeism, for example, or missed work, some socio-demographics. And we also have a voluntary section that people can choose to fill out or not. Because we launched the survey in 2021, we did borrow some questions with permission from John's surveys, or OCAL's surveys of looking at COVID impacts on work. So what is the Healthy Work Survey in general? We're offering it as a free and online tool. We were so impressed with the Stress Assess and its availability to Canadian organizations. We wanted to do something similar with the US, for US organizations and for individuals. It takes about 15 to 20 minutes to complete. It's anonymous, completely anonymous and confidential, so we don't collect identifiers. We are able to send a free automated report to individuals who choose to provide an email address. And then once that report is sent, we delete the emails, and they're not stored with the data, so it's completely separate. We can also create a group level report for organizations, and I'll explain a little bit how that works. But in these reports to individuals and organizations, we're able to compare the scores to scores like I mentioned, in the nationally representative Quality of Work-Life Survey. So these are the major domains that we measure. The 55 items are collected in these areas: job demands, job control, social support, rewards, which is very similar to the effort, reward, and balance components. We ask about respect, fair earnings, job security, respect, fair earnings, and promotions. We have 2 items on work-life balance. We do have a lot of questions from the Quality of Work-Life questionnaire on work arrangements. We're able to ask about mandatory overtime, obviously work hours, And the precarious employment section, I think, was really important to capture irregularity in scheduling, wage theft. We have items in there. But we also included a section on workplace justice, which includes questions from the Workplace Bullying Institute's Workplace Bullying Annual Survey, as well as some questions that are in the CDC GSS on discrimination and on sexual harassment. So those can be compared to national percentages as well. So the way it works is that for now, and we hope to develop a more fluid or streamlined system, but organizations can request access. They fill in a short form on our website asking for access, and then we communicate with a representative and send them a unique link that they can then email out to their employees, or in the case of a union, to their membership. And we discuss with the representatives as much as they want, how best to go about recruiting employees. We encourage at least 60% participation, more if it's a smaller organization. Hopefully we've gotten close to 100% in some of the very small organizations. And we're able to generate a report pretty much as soon as they're finished collecting their data, within 1 to 2 days. So if I have some time, I wanted to quickly give you an overview of how we're doing. We got kind of off to a slow start in 2021 with the launch of the survey. It was not widely promoted yet, but once we launched the survey for organizations in September 2021, we also increased promotions of the individual survey. So we've had over 2,000 individuals complete the Healthy Work Survey since 2021. There's about 1,200 or more individual surveys now. We stepped up a campaign to really bring folks into, individual workers to complete these surveys as an education tool, really. About 1,700 granted use of their data for research. I have a question in there, so they say yes or no to whether they would want their data to be part of a national database. It's about 80-odd%, so it's a pretty good reflection of the overall group. We've had over 61 requests for access to the organizational surveys. 7 were individuals. Some 54 were organizations that ranged in size from 5 to 6,000 employees. 55% of the organizations are small businesses or small organizations with less than 50 employees or staff. We've had 11 organizations complete the survey, 4 in the public sector or government agencies. Some of those are fairly large employers. We've had 2 unions, a union local and another union that was organizing workers. We've had 2 organizations from the educational sector, including a school district's administrative staff and a vocational educational institution. And we've had 3 small nonprofits or consulting firms that have also had the survey completed. We have a couple of others that are currently underway. So overall, the statistics on the demographics of the Healthy Work Survey respondents, 67% are female. So we do have somewhat of a selection bias towards female workers, which may be partly the organizations that are reaching out that have predominant employee base that are female. And we also have, we know that women in general tend to have more stress and encounter more stress on their jobs. Age range, working ages, 67% white, 13% Hispanic or Latino, 6% Black or African American. So not too far off. US populations may be a little underrepresented in terms of minority ethnic groups. A fairly educated group area of educated population, about 70% have a bachelor's degree or higher. And then you can see the occupational breakdown there, community and social services, some management occupations, education, office admin, some healthcare, and so on. This is just a picture of the individual report and what it looks like. I'm not going to go through that, but everyone can click on our Healthy Work survey, our healthywork.org page, and take the individual survey and receive a report if you choose. It's very easy to do, and just out of interest if you'd like to. This is the overall report for the organization. This is kind of just an example of the cover sheet that we send along with the more extensive report, which has a lot of colored graphics and so forth, which I'll show you in a moment. These are the areas that we break down for an organization, so they're not just flooded with all this data. They don't really know what it means, so we attempt to give them some interpretation of the data, and in order to be able to set priorities, we create sort of a red flag system. So we say, look, these are the areas that you want to pay most attention to. This data is based on the current population, the 1,700 or so that agreed to have their research, their data part of the database. And you can see that it's a fairly high risk population, which is not surprising. I think a lot of the organizations that come to us have a lot of problems going on. They know that. And obviously a lot of the individuals that are coming to the website may also be experiencing more work stress. So I'm leaning towards this being a more selective population than a nationally representative population, of course. So you can see that in general, there's pretty high job demands reported. That's in the high risk score area. 63% report, the highest level of job demands, workload, 47% low resources, 52% low job control, which includes items on decision latitude and also on skill discretion. And again, you can see that there's some variability in the middle. The groups averages can either be high risk, low risk, or intermediate risk. So you can see there's several that are in the intermediate risk area. And then lastly, down the bottom here on the left, we have the two questions that we use to look at emotional demands. The first one is your job always or often emotionally demanding? 63% said yes. Now, something to discuss at some point, obviously, is whether or not we want to clarify that question to some extent. We're considering it to ask people first if they work specifically with the public or with, clients or patients or in some kind of human service position. It's a longer debate than we have time for here. And then the other question is a question that reflects kind of the surface acting element of emotional labor. This is the percentage of people who say they always often hide feelings at work. So it kind of taps into that emotional dissonance effect from being in a highly emotionally demanding job. So as I mentioned, we have those red flags, which are automatically, there's an algorithm in our data set and it's coded so that we give a red flag to those organizations or individuals that have average that is higher than the US national average. And also the percentage of people at high risk in that organization is higher than the US percentage at risk. So using that table that I showed you on the three group classifications. And then we, of course, recommend prioritizing those stressors. And we always discuss with organizations that want us to, not to ignore the other factors, but that if you are attempting to implement changes, it's always good to start with what we consider the most high priority issues. This was data that we collected from the same population, the entire population, pretty high percentage reporting experiencing workplace bullying. 31% reported witnessing it, which is much higher than the Workplace Bullying Institute annual survey. So this may represent, as I said, a highly stressed population. 3.6% reported workplace sexual harassment specifically in the last 12 months. So similar to the US percentage. This is from the GSS and NIOSH Quality of Work-Life questionnaires. And then the question down below is on whether you feel discriminated against at work due to your gender, age, race, ethnicity. We added religion and nationality and sexual orientation, but we do not have national data to compare those two. But you can see this group definitely has a much higher rate of experience of discrimination. The physical hazards, in general, it's not as I think there's a less representation of blue collar or manual workers, although we do have facilities workers and others in the data set. 16%, report some kind of exposure, daily or weekly. Those questions were. The high physical effort question was part of the National Quality of Work Life questionnaire. So you can see it's slightly lower than the US percentage of high physical effort. And then down the bottom here was the question on exposure to physical violence in the workplace. And we separated it again based on personally experiencing an assault or witnessing physical violence there. So we do not have national data on that either, unfortunately. This is the type of employment arrangements. You can see that the majority of folks are working full-time that fill out the survey on day shifts. They're salaried or hourly, almost 50-50. The average work hours was 42.5, and 26% reported working 50+ hours. So it's somewhat similar to the US average of folks working long work hours. 29% approximately reported having to work mandatory overtime. No particular issues in terms of precariousness in this broader population. There were some 13% of folks who reported not being paid overtime. And then 24% reported that they had regular changes to work time arrangements. So, almost one in four workers here. And unfortunately, the schedule changes that those workers reported were pretty highly irregular in terms of being either spontaneous, the changes, or on the same day or the day before. So definitely a concern there. These were the COVID questions. There were 1,100 folks that answered these questions out of the 1,700 that we have data for. At present, includes everyone from 2021 onwards. Those working at home, 43%. It may have been a lot higher back in 2021 than it is today. Interesting, the psychological health and safety question, which was also, I think, derived from John's work and maybe part of the COPSOQ, I think, was 50%. We combined the lower end of the answers to look at psychological health and safety being toxic, fair, poor, or not so good. And it's around 50% in this population. The population also has worse mental health than the US. As I've said to organizations, this may or may not be due to the working conditions issues, but we do have a lot of research evidence that there is a relationship. Many of them commented on the fact the pandemic might be inflating these health outcomes, which is highly possible. Maybe when we have the 2022 data, we will be able to say a little bit more about that. But you can see that it's fairly high. 74% were reporting exhaustion, feeling used up at the end of the day, often or very often. It's only one component of burnout, I know. But in a short questionnaire, it's sort of a proxy measure there. 70% of this population reported stressful work often or always, which is really high. Most national surveys using this question are usually around 30%, and they've maybe gone up slightly since the pandemic, for sure. And then lastly, the questions on depression, on chronic health disorders. You can see very high percentage of folks reporting that they have a doctor diagnosis of depression, 39% compared to the US at 16%. Now we may again see these go up as we look at the 2022 Quality of Work Life questionnaire data, which I don't believe is out yet, but don't hold me to that. I probably am out of time here. I don't want to go much much beyond this, but just to say that we do have resources that are also available to these organizations. We have a plan that we can report to them in terms of how they can use these findings in their organization, involving different levels of the organization, especially employees. And we have a few organizations that have actually implemented changes, especially the one particular union that was able to really use the data and make some very sizable changes with management to improve worker health and well-being. And we have a large public sector organization that is committed to an ongoing assessment and implementing changes to improve healthy work, and committed to the idea of healthy work, these same ideas which are reducing job demands, increasing job control, and so on. So just a quick summary and next steps. We've had a lot of positive feedback about the system overall. It works pretty well. We do need to conduct further studies on and look at some of the questions and evolve the survey eventually. We wanted to start doing that. We do find that a lot of small organizations are interested in requesting access and are more likely to implement, which I think says something about the nimbleness of an organization. Even though they have fewer resources, they may not be as daunting to survey 20 or 30 people versus 1,000. So there are some significant barriers to participation in the US, of course. It's completely voluntary. There are no standards and no laws that require employers to do this. And we continue our outreach efforts, including education and this Healthy Work Pledge and other forms of social media and presentations and so forth to, really increase awareness. We definitely have found a bump since the pandemic in terms of people being really concerned about their workforce and their mental health. We've had a lot of folks leaving, as I'm sure you have here in Canada and elsewhere in the world, leaving jobs, especially in the public sector, teachers, nurses, public health workers, and so on. So there's a lot of staff shortages and very high workloads. And management is starting to pay attention, at least in the public sector. So that's it. I'm sorry if I went a little over time, Val, but I'm happy to answer any questions, or are we doing that at the end?
Great, thanks a lot, Marnie.
Yeah.
Does anybody in the room have a question for Marnie? Yeah, Michelle. We're just going to move the microphone over to her so everyone
Hi
can.
there.
Hi.
Just going to wait for them to shut off the echo. Okay, yeah. Hi, thank you for that presentation. Very, very interesting, and I am eager to read the paper. My name is Michelle. I'm an occupational health nurse with the occupational health clinics. So I work with John, but not specifically on the mental health COPSOQ approach. I tend to work with a lot of vulnerable workers. And it's certainly by looking at your data that there was responses from vulnerable workers, some of the data that you had shared. And this may be a naive question, but I'll ask anyway. Because you were developing the survey, that I'm wondering whether there are any measures or any examination in terms to try and get a handle on accessibility. And by that, I mean accessibility to like workers. I understand to the organizations, you've explained that, but how, whether there was any attempt to measure whether this would, how accessible this would be to, say, an average worker.
Yeah. Well, I think that would be a great plan. A lot of our promotion we're doing right now through the internet. So it does, the access to the internet is somewhat of an issue for some vulnerable workforces, for sure, because not everyone has access to a computer, although we know the rates of using smartphones have gone up. I think stress is kind of one of those issues that is a challenge as well as healthy work for the most vulnerable workforces, not because it isn't a real issue for them, but because they're just trying to get by, right, and survive. So, you know, you look about the hierarchy of controls, you know, the important things are getting paid, you know, getting paid a living wage, especially here in the US. And, you know, I think other issues like being treated with respect, with dignity, not being bullied, not being exploited in terms of, you know, being treated fairly, you know, by employers and not, you know, have their hours cut if they complain, things like that. There's a lot of elements that I think we could capture in the survey, and we're actually working here in the US. We've already started translating the survey into Spanish, because a lot of our vulnerable workforce are Spanish speakers, especially the immigrant workers and farm workers, as well as home healthcare aides. And there has been some research in that area. And I think our next goal is to kind of take this out to more vulnerable workforces and get, you know, specific feedback. We have had one, I mentioned a union that had a sector of facilities workers, and they were working night shifts, and some of them had serious health problems, and which were being exacerbated by these night shifts. And the, you know, supervisors and management were not listening, were not caring, and there was a lot of conflict and a lot of stress. And we, with the union's request, we conducted a survey with them. The steward actually sat down when she knew them. One of them was her husband, and they actually we did the survey with them, and we got almost all of them to do it. And we were able to use that data to then go back and the steward talked to them about, you know, what could help and what would change. And they, with that as well, they were able to talk to management, which was, you know, they have a receptive labor management health and safety committee. So it was able to be, there were changes implemented, you know, maybe not directly resulting from the survey, but definitely starting to listen to workers a little bit more.
Thank you very much for that. And
Yeah.
I'll continue to be in touch with you as you work with the migrant population.
Yeah, that would be great. And I'd love to get your ideas and thoughts about it too.
Exactly going to be my question. I had two questions, particularly was, is it available in Spanish yet? That was going to be my first question.
Yeah,
So
yeah.
you're already making, what does that look like from a timing perspective?
Well, the translation part of it is pretty, you know, is working out, but we really do want to field test it for the cultural validity element. And we had, you know, made a sort of a plan for a mini research project where we were going to partner with their labor occupational safety and health program at UCLA, LOSH, and they have a lot of outreach efforts with migrant workers and with low-income low-wage Spanish-speaking workers. So it's just resources that you know holds us up there. But you know we're working in that direction. You know, we're a small nonprofit organization, so I wish we had you know the resources of a NIOSH, but we're doing what we can.
Great, thanks. I really appreciate you joining us again this year, and it's been really interesting for us to watch the progress that you've made, and we'll continue to invite you back. And I think it's a good entry into the rest of the dialogue here in this session about how surveys are used around the world, the COPSOQ and others. So yours is sort of grown and morphed from the COPSOQ and other questions that you found. So
Yeah,
John
absolutely.
has been facilitating the next section, I guess. So do you want to come and, although we are, yeah. And so we had a number of volunteers to share their experience. So John, want to come up?
Yeah, I thought we'd keep this a fairly small group here, and I don't know about online. 27. So the idea was to, number one, share what kind of legal environment psychosocial risk assessment that is going on in your country, and share a little bit about the practice. I think maybe I'll start in Canada just so you have a bit of an idea of what we're looking for. In Ontario, we have no requirement to do psychosocial risk assessments. We have legislation that requires companies to have policies for violence and harassment policies and processes to investigate those policies. We first only had the requirement for a policy, but later on they realized you also have to have a process to enforce it. In compensation, PTSD was compensated for quite a while. Acute stress responses. More recently, we are compensating chronic stress. However, as a newspaper report just last week reported, is that 90% of claims are being denied because the bar for psychological illness is higher than for physical occupational illness. For physical occupational illness, the bar is a significant contributing factor, but for psychological disability, it's the predominant factor. Although the WSIB is saying that that's not the main reason why they're being denied, but that is two different standards, and we're concerned that psychological problems or illnesses are not being treated the same as physical illnesses. And on the practitioner side, we had the standard that you've heard about today that many organizations are looking at. Some are trying to implement, and there are two tools. There's Stress Assess, which you've heard about, and Guarding Minds at Work, which is another free online tool that can be used. There are other English language ones. In Australia, there's People at Work, and in Ireland, they took the UK HSE management indicator tool and made that an online survey along with the GAD2 and the PHQ2. So those are the tools that are available. In practice, we have a number of health and safety associations that have created websites and done some education on how to help people, workplaces deal with mental health, reducing stigma, providing resources for those who are having problems like return to work and health or mental health first aid. Those have generally been focused on helping individuals who have problems. There's also a First Responders First for PTSD for first responders, programs to identify and help them. But these are all voluntary, and I think that's about it. Now, I have a recorded contribution from Iran, and also I've heard from Fatima in New Zealand that she would also like to share about New Zealand. So maybe I can propose that we do the online people first and then go in the room, if that seems reasonable. And I think Argentina also was willing to share. So maybe if we can start with New Zealand. Fatima, are you there? You got to realize over there it's about 12 hours different, so it's 16 hours later. So
hi, John.
Yes, there she is.
I'm here. I wondered what did you want me to share in relation to our national health and safety regulators survey that they have done nationally. Is that what you want me to comment on?
I think right now we're looking at what kind of legislation you have regarding psychosocial risk assessment in New Zealand and what the actual practice in the workplaces is.
So similar to Canada, my understanding is that our psychosocial risk assessment is not mandatory or legislated by or that organizations have to do it. It is voluntary. Some organizations do it and others don't. Some do it in piecemeal, if you know what I mean. Like they would check on different aspects. We do have voluntary coverage available in terms of resources that you can apply for once you go to counseling or psychiatric help and you get some diagnosis, so you can seek help at an individual level. But are organizations doing it at an organizational level, or do we have a policy? Not really. In New Zealand, it's not. It's still all very similar to what you were explaining. However, our National Health and Safety Regulator did do a nationwide survey, which wasn't compulsory, mandatory, or any such thing. It was all voluntary for organizations to participate. So we got 3,000 plus responses, which in New Zealand context can be considered as a large scale survey comparing our population. But we did not capture the we won't say that we captured all the demographics within New Zealand, or we captured all the marginalized groups in New Zealand in terms of work life. For example, tomorrow's presentation, where I'm presenting the work that we are trying to do with the fishing industry, almost had almost nil representation in the nationwide survey. And considering that we are islands, it's a very important population segment. So when you look at our data nationwide, you see that we don't have a lot of data coming out of organizations. We have a lot of data on bullying in specific, but not broadly on psychosocial risks. So it's something that is coming to attention. But that's where we are. Have I answered the question?
Yes. And what about compensation? Is work-related chronic stress compensated in New Zealand?
Without having us no. I mean, we do have compensation if you are taking time off, but not like for PTSD, for example, like you were explaining, or if you are diagnosed with a particular disorder through a professional diagnosis, then you can apply. But is there like a overall overarching policy? No, not at the moment. My understanding is no.
Okay, thank you. Maybe we can switch to Argentina. Johanna Gerka.
Yes, hello, how are you?
Good, how are you?
I couldn't hear you for 5 minutes.
Okay, you're back though.
Here I am. Well, in Argentina, we hadn't any new development in relationship to what we presented in 2021. Here we have a working health insurance system. About the preventive aspect in this system, we have two regulations that only mention the psychosocial dimension for working conditions and health. one from 1972 and the other from 2003. So unfortunately, we still don't have any compensation policy. I was hoping that you were more developed. The system only recognizes and repairs working accidents and listed illnesses. It recognizes illnesses that are listed. That means that, for example, cancer. No, you have to find a relationship between one working risk and one working activity. So I don't know if you all have insurance systems, if anyone solved it, and if you can share with us these regulations so that we can have them as a goal.
Okay. Well, I think we'll share first, and then maybe you can extract like from some of the others what the goal is. At this point, I want to share the video from Iran. Mohsen, are you there?
Hello, John. Yes, I'm here. If you have my sound.
Okay, I shall play your video, and then we'll see if anybody responds.
Yes.
Yeah, share.
Here I am. Yes, of course. Yes. Does the video present the sound, or I should explain myself here?
Okay. Hang on, I made a mistake.
I think it's correcting the experience of sexual in Iranian workers. Yes. Hello, everybody. I wish you the best. Hello to all present audiences. As the program started, for the experiences of psychosocial situations in any countries, I will present you the psychosocial situations on Iranian workers with COPSOQ experience among Iranian workers in huge industries. As we know that Iranians has a different culture, and the psychosocial situation of workers in Iranian culture can be influenced by a variety of factors, including cultural norms, economic conditions, and of course workplace policies. The Iranian culture places a strong emphasis on family and community, which can lead to a sense of collectivism and a desire for social harmony in the workplace. However, this can also create a pressure to conform group norms and expectations, which will limit the individual's expression and creativity. Workers' psychosocial well-being is essential for individual and organizations' success, of course. In Iran, several challenges affect their well-being, such as job insecurity, work overload, and lack of social support. Understanding these challenges can help to develop the effect of interventions to promote workers' well-being. The psychosocial factors, as I said, the economic conditions in Iran can also impact the psychosocial situations of workers. High level of unemployment and underemployment can lead to job insecurity and financial stress, which can negatively affect their mental health and well-being. Additionally, workplace policies and practices such as long working hours and limited opportunities for the advancements can contribute to feeling of burnout and dissatisfaction among workers. As I mentioned, the job insecurity in Iran is a major concern for workers. So it led to stress, anxiety, and depression affecting their psychosocial well-being. Work overload is another challenge that affects the workers' psychosocial and their health, and it leads to burnout, fatigue, and reduce the job satisfaction, of course. Lack of social support is a challenge that workers need to social support from colleagues or their supervisors to cope with all job demands. Employers need to create a supportive work environment to promote workers' well-being. Workplace policies such as long working hours, low income, low injustice at work, fake jobs, unspecialized tasks, of course, may make them dissatisfaction and make them confused of their task anyway. As a solution, it's important for employees to and the policymakers to consider the unique cultural and economic factors that influence the psychosocial situations of the workers in Iran, and to develop strategies that promote positive mental health and well-being in the workplace. Several interventions can promote workers' their well-being in Iran, such as employee assessment program, psychological counseling, and stress management training. These interventions can improve workers' health and their mental health, of course, and productivity. Several studies in Iran that showed some situations and made us some information about this. A study published in the International Journal of Occupational Safety and Ergonomics in 2019 used the COPSOQ to measure the psychosocial factors among Iranian nurses. This study found that Iranian nurses reported a high level of job demands, low level of control, and moderate level of social support. This study also found that these factors were associated with a higher level of stress and burnout among nurses. The other study among hospital workers in Iran, which was published on the Journal of Occupational Health in 2018, used with COPSOQ, measured the psychosocial factors among Iranian and hospitals. The study found that Iranian hospital workers reported high level of job demands, and also in addition to the above study, they mentioned a higher level of job stress and lower level of job satisfaction among the hospital workers. In our study, also in addition, both above conclusions and results, we found a high level of job insecurity, high level of burnout, low self-confidence in workers, high work pace, low sense of community, and of course low justice in the working. Overall, these studies suggested that Iranian workers may face significant challenges related to job demands and control and social support, which can negatively impact their mental health and well-being. By using the COPSOQ to measure these factors, organizations and policymakers in Iran can gain valuable insights into the specific psychosocial challenges faced by workers in their context and develop targeted interventions to promote workers' well-being. With this information, we conclude that the psychosocial situation of workers in Iran culture are complex and, of course, multifaceted and require enhanced understanding of cultural, economical, and workplace factors. By prioritizing the mental health and well-being of workers, employers, and policymakers can create a more positive and productivity work environment for all. We found two programs to better the situation in this way. The social ergonomics is a new approach with ergonomics principles that can, of course, decrease the effects of social supports and social problems with an ergonomic solutions and principles among the workers. And the other one is organizational concept, is a new method to design works and make workstation and workplace as a emotional workplace. And the other one is the programs of consulting ergonomics that we promote and provide consulting programs for workers and maybe their family if needs, and for employers, of course, to have a better situation and better design networks to at workplaces to make an ergonomic environment and better social situation for the workers. Thanks for your attention. I'm Mohsen Abadi and ready for your questions among these present. Thank you, John, for playing the video. I'm here for any questions if. Excuse me, John, I don't have your sound. Sorry about it. I think there's a. Sorry, I think we lost your sound.
And I think you are mute.
Mr. John, yes, please.
I'll try again.
Yes, that's it. Yes, you have it.
Is there any regulation or regulatory requirements in Iran for workplaces to assess psychosocial conditions?
You know, the most recent instrument and tool that we can analyze and we assess the workplace, of course, in a workplace of Iran was COPSOQ, as we could translate it recently in Persian. But in another way, we have assessed the Persian workers with other quality questionnaires, not exactly any dimensional questionnaires such as COPSOQ. We have found it that recently and till COPSOQ was presented in Iran, we could find the pace is very different in our workers and is very affect the psychosocial situations.
Is there any law requiring assessment?
I should say that sorry, there isn't any law to control them. It's recently have mentioned as a psychosocial factor in environments, and there is no rules to control them to release the pace of the works. There are just regulations as are evenly matched and or evenly have been found that this pace is harmful for people or not. But there is not a certain regulation from the organizations or from governments as a work rule, if you call it.
Okay, thank you.
Yes.
Anyone else? If not, we'll move to Europe. Anna, do you want to describe which country? Sweden or? Okay. Okay.
Well, the short response is yes, we have regulations, and yes, we have legal ground for not just assessing risks, but also for managing risks and psychosocial risks. But it is more comprehensive in Sweden than just psychosocial risks. Actually, we have also a focus on positive factors like resources in the work environment, and not just a requirement of preventing stuff, but health promoting. So I think Sweden right now is among the countries in the world with the most extensive legislation on this area. But at the same time, in Europe, we have, in general, in the European Union, minimum standards for psychosocial risk management and risk assessment. So all European countries have to adapt to the legislation in the European legislation and then add national layers to it. And compensation, yes, we have compensation systems for all kinds of occupational injuries and illnesses, including stress and burnout. But it is more difficult to get compensation for psychosocial risks or burnout from stress. I think the burden of documenting the connection to the workplace is harder. So that is something that is worked on.
Oh.
So we also have France and Germany and
Germany.
Good afternoon, everybody. Germany has not a lot to add because it's in Europe and there is a European legislation, and the European legislation is saying that you have to do risk assessment. Then every country does what it wants, but it has to do some risk assessment. And in former times, risk assessment was more technical risk assessment, let's say electricity or something like that. But now it is in the law that you have to do also psychosocial risk assessment. I think there are some statistics, Herman probably knows it better, but not even half of the enterprises in Germany have done psychosocial risk assessment, even if the law exists since many years. Some do it, some do it not. I have heard only 2 or 3 times that there was a fine from the authorities for an enterprise not doing it. Usually there are some that they say you have to do it now, you have to do it, some pushes, but I have heard rarely that somebody got punished because he did not do it. And what was the other one? Our compensation. Of course, when you are ill of psychosocial reasons, you get your illness pay, like if you have a broken leg. But there is no professional disease for psychosocial factors for the moment. There is for other factors like back pain, there is a special cipher 2108, and usually nurses are more likely to get it because they can demonstrate that they have done some heavy lifting. But there is no such thing that you can say, I have been a social worker, and so my psychiatric disease now is due to the work. There is no regulation in that sense. Franz, where are you?
Hello. In France, is more the same like in Germany because it's Europe. It's in the law. You have to assess psychosocial risk, and you have a compulsory of success to preserve mental health of workers. So it's a real obligation for companies to do things about that subject and to assess also the effect of your action, etc. And we have the same like in Germany. There are compensation because if you are ill because of the work, you have ill pay to compensate it. But maybe 5 years ago, the question to recognize burnout like a work disease, there were a lot of debates about that, but at the end, they didn't put this disease like a work disease. So you just have to compensate, you'll pay if you have a problem that subject at work.
If maybe you can elaborate. I heard about this in 2015 when we were in Paris, but you actually have, if you find something wrong with your psychosocial risk assessment, you have to demonstrate that you fixed the problem.
Yes.
And at one time they were going to put people's names of companies online of who did it and who didn't.
No,
No,
they didn't do that, but work inspection inspectors are really regarding about what companies do, and if they do not, if you don't do anything, they have to pay money to compensate the cost for the French society.
Mm-hmm.
Almost that, but it's not publishing online.
Okay, thank you.
I don't have the microphone. So yeah, there's a question, Hannah, for you from Johanna about when you were presenting, but I didn't see it in time. That asks about, I don't know if we can, no, I can't open it up. My phone's not cooperating. Johanna, you could actually come on and unmute your mic if you want to ask the question.
I was asking, maybe if you don't have an insurance system, it isn't a problem. But here it is very difficult to find the relationship, to establish a hard relationship between the exposure and the illness, because the insurance companies doesn't want to pay it. Is it like this in Europe?
US.
I'm not sure I understand the question completely. Well, I think there are two different things. There's one thing about having illness absence and being compensated, and there can be something about if you have long-term illness and can't return to work even after trying to be rehabilitated. So how to establish it? Well, I think that is a very difficult question and I can't really reply like this, but we have a new kind of workers that are called rehabilitation workers that support the system in dialogue between the worker, the company, and the insurance system. So, but I can't the details about how you make the links.
It's okay. Thank you.
Maybe I can describe some of the problems here in Ontario. In order to, up there.
Yes, I'm hearing you.
In order to prove that something is a psychological disease is work-related in Ontario, you have to show that it's the predominant cause, and therefore they look at your psychological history. So if you have a history of depression, or if you have had a serious problem in your marriage or something like that, they will attribute they will say that work cannot be the predominant cause. So that one of the questions we've been asked is, can you use the COPSOQ survey of the workplace to prove that there was a psychologically harmful environment that could cause that disease? The problem with that is it's a group analysis and you're applying it to an individual. So you can have an individual who's in a group-wise, a very healthy workplace, but they're having toxic relationships, which is kind of unique and not common to the rest, or the reverse. Sometimes they will be, the group and the individual will be in sync. So that becomes complicated. But yes, we have that problem also. But Germany does not compensate chronic. Yeah.
May I put a comment here? Recent research indicates that that people who already have some signs of a disease, they are much more vulnerable to poor psychosocial working conditions, developing this disease further. Okay, so if you have a compensation system saying that you have already some signs of the disease, then you can't be compensated for working conditions, and then you are in fact belonging to a vulnerable group where these conditions are a much worse risk. So it is contradictory to research evidence that such people that such people would not have a chance to be compensated. That makes no sense.
Yes, and these people who are vulnerable are actually the canaries. And if you ignore the message from the canaries, we know what happens to the coal mine. I don't know if that helps, Johanna. But
Yes, thank you very much. We are going to do much more questions these days, but it was enough for today. Thank you.
Yeah. At least we can commiserate with your issue. We don't know the solution. Yep, so.
It's a question. It's a question for Hannah, really, though. Do I understand that everyone would get compensated anyway? How it would work, you don't know. You have these rehabilitation people that are helping with the compensation piece of it, but everybody would get compensated?
Well, not everybody will get compensated, because if you can't establish a connection to that it is a workplace thing that has made it, but then you have other compensation systems in Sweden. As a welfare society, we have different insurances and different retirement pension opportunities and things, but it is really a very complex thing that I'm not into the details of.
Okay, all right. So if someone did have an occupational disease, like unlike Germany, there would be other methods of compensation, even if you could not prove a connection to work.
Yeah, you have other opportunities of getting a wage. Yeah,
Yes,
not a wage, but
living.
Some living accommodating living. Yeah.
Okay, thank you.
Yeah.
Well, maybe I can ask Fatima. I know that New Zealand has explored the guaranteed income. I don't know how that went, but if everyone has a guaranteed income, does it really matter whether or not it's work related if you're compensated similarly, whether it's work related or not? It just becomes an accounting issue about who we charge it to, or how does that work? Do you know, Fatima?
I can't answer in a lot of detail, but I was just going to make a comment in relation to New Zealand, is that the government tries to compensate anyone and everyone that they can in case of any harm or loss of work at work, or especially if it has happened at work. There is a lot of room for people to negotiate with their organizations to seek the sort of the best possible solution, because if you look at our Health and Safety Act and the legislation, it provides a very broad definition which can encompass quite a lot of things if they are taken forward as a process. I don't know whether that has answered your question or not. Guaranteed income in case of people not like losing work, there has been different different I'm sure I'm trying to get my the right word, that came from the government at particular points in time as additional benefits that were being offered to people who had lost wage entirely or partly, that they could write to our IRD, our internal revenue, and they could get the compensation back to them, given back to them. Beyond that, I won't exactly be able to comment. But New Zealand government and New Zealand policies, in some places, you could say that they are not very black and white. And in those cases, they are most often used to the advantage of the employee or the worker rather than the other way around. So it is to give more wiggle room so that they can accommodate the issues that the employees may be facing. At times, it is to be negotiated with their organization. But at other times, like you were talking about, if you're talking about loss of work hours or loss of jobs, that those were directly, you would receive notifications through email or through post, and you could actually reply to them explaining what has been happening. Even if you were a private owned business which was losing business, and then they would process your case and look into it. Have I answered the question?
Sort of. No, I guess when I'm dreaming in Technicolor, I think of a universal compensation system that covers everybody's accidents and illnesses, whether it's at work or not at work. And if it was at the same level, no one would have to prove or disprove whether or not it was work-related. If everyone was looked after, then all the people who make their earnings, like lawyers, arguing that it's work-related or not work-related, or our clinic arguing that it's work-related or not, would not matter, except for accounting purposes. Herman?
Sorry, you go. I lost you in the middle.
In fact, one of the founders of the Copenhagen Psychosocial Questionnaire, he wrote an article in the 90s in Danish, unfortunately, where he said, suppose that everyone who are ill are treated in a way so that they get what they should need. We do not need a big bureaucratic system consuming a lot of working hours in order to find out if a disease is work-related or not. Because then we can just treat people well who are ill, and we could use all the energy in order to establish if an individual is ill or not, for preventing that such things could happen both in workplaces but also outside of workplaces. Maybe I should see if I can find that out paper and have it discussion paper and have it translated.
That's my dream. Okay, it's 3:30, and so I want to wrap things up and thank you very much for attending, both people in the room and virtually. We really appreciate your contributions. And for those of you who are coming back tomorrow, we'll see you tomorrow. And have a good evening, and thank you very much.
Yep, thank you to everyone online for joining us again and sticking with it as we tried to figure out how to do this in a hybrid way. And looking forward to seeing you. We have 3 more weeks of Mayday Mayday on the 17th, the 24th, and the 31st. So go to our website and sign up for those sessions, talking about youth mental health next week, talking about crisis management and PTSD on the 24th, and talking about tools and resources, including some of the other Health and Safety Association products and services on the 31st. So looking forward to seeing everybody then. And thanks again to everybody who joined us from around the world, in the room and online. So see you next week for those of you who will join. Bye-bye.